Good afternoon, and thank you for the opportunity to present our research this afternoon. First, I have no disclosures. So paraesophageal hernias can either be asymptomatic for patients or they can have a variety of symptoms, ranging from gastroesophageal reflux to various obstructive symptoms, including early satiety, dysphagia, and epigastric pain. Because of these symptoms or the actual pathology of the hernia itself, patients can have a variety of complications. The two that we're going to focus on are hypoalbuminemia and anemia. Because of the symptoms, if a patient has them, they can often modify their diet, which leads to weight loss and subsequent hypoalbuminemia. For anemia, this actually occurs in 9 to 15% of patients with paraesophageal hernias. This is thought to occur due to the compression and partial volvulus of the herniated stomach, which then develops Cameron lesions at the level of the diaphragm. These have been shown in previous studies to occur in 10 to 20% of hernias that are greater than 5 centimeters. The majority of these lesions do resolve with repair. Previous studies in other areas have shown the impact of malnutrition and anemia on outcomes in surgeries such as cystectomy, joint arthroplasty, inflammatory bowel disease, and hepatectomy, but no studies have been done looking specifically at paraesophageal hernia repair. Given the prevalence of these complications in patients with paraesophageal hernias, we thought it would be prudent to investigate the relationship. So for our study, we used 5 years of data from the NSQIP database. We included patients who had their primary surgery was coded as a CPT code for paraesophageal hernia. We included laparoscopic, open, thoracic, and thoracoabdominal cases. For anemia, we define this as a preoperative hematocrit, less than 36% in females and less than 39% in males. This was consistent with the World Health Organization's definition. For malnutrition, we define this as a preoperative albumin of less than 3.5. And both of these lab values, all the preoperative lab values, were obtained within 90 days of the surgery. For our postoperative outcomes, NSQIP uses 30-day outcomes, and for our morbidity variables, we included surgical site infections, urinary tract infection, venous thromboembolism, myocardial infarction, acute kidney injury, pneumonia, reoperation, readmission, and mortality. We also looked at length of stay. For our statistical analysis, we did a binary logistic regression to evaluate the difference in morbidity and mortality, and an independent samples t-test to evaluate the difference in length of stay. So first, overall, we had over 15,000 patients that met inclusion criteria for our study. This was about a population of about 71% female with a median age of 63. The vast majority of the cases, almost 89%, were performed laparoscopically, and 3.6% of the cases were emergent. So from this overall population that we included, we then did sub-analysis from here, an anemia analysis, a malnutrition analysis, and then analysis for patients that had both of these conditions. So first, for our anemia analysis, we had over 13,000 patients who had a preoperative hematocrit available. This was 87% of the cohort that met the inclusion criteria. The average female hematocrit was 38.6%, average male was 41.4%. This left us with a population that was 23.1% of our population was anemic. For our malnutrition analysis, there were 7,900 patients who had a preoperative albumin. This was a little over half of the overall cohort. The average albumin was 3.9, and 13.9% of this cohort was then malnourished. For our analysis that included both anemic and malnourished patients, this was over 6,000 patients had both preoperative lab values available. This was about 40% of the patients that met inclusion criteria. And this left us with 4.5%, which was 682 patients that were both anemic and malnourished. And for the analysis when patients had both conditions, it should be noted that these were being compared to patients who then had neither condition. So this table shows the difference of incidence in our various morbidity and mortalities. So for patients who were anemic, they had a higher incidence of urinary tract infection, venous thromboembolism, myocardial infarction, pneumonia, reoperation, readmission, and mortality. For patients who were malnourished, there was a higher incidence of everything: surgical site infection, urinary tract infection, venous thromboembolism, myocardial infarction, acute kidney injury, pneumonia, reoperation, readmission, and mortality. And for patients who had both of the conditions, there was again a higher incidence of all of the outcomes that we investigated. So when looking at length of stay, anemic patients stayed about a day and a half longer than non-anemic patients, 4.1 days compared to 2.8. Malnourished patients stayed almost twice as long, 6.1 days compared to their counterparts at 3.1 days. And patients who were both anemic and malnourished actually stayed over twice as long, 6.7 days compared to 3 days. This figure depicts the increased risk that a patient has for the morbidity and mortality variables that actually were different within that group. So this figure depicts the increased risk in the setting of anemia. As you can see on here, the highest increase in risk was in myocardial infarction with an increased risk of 4.3 times. This was closely followed by mortality with a 4 times increased risk. For malnourished patients, the greatest increased risk was in mortality with a 7.8 times increased risk. The next highest was then pneumonia with 3.7 times increase of their risk. And patients who had both anemia and malnutrition, their highest increase in risk was in mortality with a 12.7 times increased risk. The next highest was myocardial infarction, which had a 10 times increased risk. So paraesophageal hernias inherently from either the hernia or the symptoms they cause can lead to anemia and malnutrition. And this anemia and malnutrition are associated with higher morbidity, mortality, and a longer length of stay. We can then use this information to hopefully target nutritional deficits to optimize patient outcomes preoperatively, and providers can also use this information to set realistic expectations with patients when doing preoperative counseling. Thank you, and I'm happy to take any questions.
Questions from the audience?
I just have one question. Do you really think that it's the anemia and the hypoalbuminemia, or do you think these are just surrogates for sicker patients going into surgery?
They could be surrogates. We did control for emergent cases because that was one thing that we thought could easily be a confounder here, but there was actually minimal difference. All the odds ratios changed less than 0.5, and all of them that were significant remain significant. But whether it is a surrogate for a lower functional status or something else, that's hard to tell in these retrospective databases.
Very nice.
Thank you.
Thank you.